Okay, so we are doing this training series, kicking it off now in honor of Mental Health Awareness Month. And our first training, recognizing signs and symptoms of mental illness. We will also discuss differences in African American communities regarding health disparities, as well as the impact of COVID-19 on everyone. Before we start, we want to thank you and thank the ReCAST, St. Louis ReCAST, for supporting today's presentation. If you are wondering, ReCAST is an acronym that stands for Resiliency in Communities After Stress and Trauma. In 2019, Places for People was one of 4 nonprofit organizations awarded a St. Louis ReCAST grant, with a focus on bringing mental health awareness to the Promise Zone. The Promise Zone encompasses portions of North St. Louis City and it extends into St. Louis County. A little more than half of the individuals and families served by Places for People live in the Promise Zone, but we know there is so much work that is needed to provide access to members of this community and eliminate stigma associated with seeking support for mental illness and substance use disorders. Your participation in events like this will help that happen. So thank you so much for being here. I want to say that right now we're going to leave people on mute and ask you to type questions into the chat box. And we will keep an eye on that, and Megan will be stopping routinely to answer questions, but just with a bigger group, it's hard to leave everybody's mics open. So please, if you have comments or questions, put them in the chat box. And also, I'm excited to get started. So thank you, Megan, for doing this, and thanks everybody for joining us.
Awesome. Thanks, everybody. I'm going to go ahead and start sharing my screen. Like I said, if you guys have questions or comments, please go ahead and put them in the chat box. We'll be checking that kind of in between each slide just to make sure that we've got folks' questions answered. So this is my first Zoom training. So thank you for joining me on what might be a really wild ride. So bear with us as this is our learning curve. So my name is Meagan Doty. I am the program manager for our outpatient clinic at Places for People. I am a social worker by profession, but currently do trauma therapy. I've been working with Places for People for many years in a variety of capacities, and I'm really excited to be able to share the stuff that I've learned over the years with you all. Just to let us know where we're at here, we'll be discussing, as Julie said, some information on a variety of behavioral health issues, specifically impact that COVID-19 is happening, how y'all can help, community resources as well. Just so you know, we've already gotten a couple questions that I wanted to make sure if you sent those in, you know they'll be answered. One was regarding anxiety, which we'll address when we get to that section. Another is strategies to engage clients that might be afraid of stigma or might be in denial about their symptoms. So we'll talk about that as well. And a really interesting question I got was, are there differences in symptomology and or diagnoses based on cultural or regional, as in country differences? And I thought that was a really interesting question. Absolutely. So some really great examples. As we learn more about mental health, behavioral health, our diagnoses changed. The DSM comes out with a new version every 10 or 15, 20 years. And so for instance, you know, in 1973, homosexuality was taken out of the DSM-5 and is no longer classified as a mental illness. Prior to that, it was. And so a lot of that had to do with cultural differences. When we speak about, you know, around the globe, I worked in East Africa for a little while, and individuals with schizophrenia in many rural East African areas are actually seen as more as community leaders or shaman, or folks that are more closely connected to the ancestral world. So as opposed to being stigmatized as having a mental illness, they're actually lifted up as people who have an extra special connection. So things do differ around the globe, as they differ when we have more knowledge, more information, more research based on symptomology. So this is definitely an ever-changing field. I want to go ahead and give you guys a couple minutes to go ahead, and if there's anything that you would like to get extra information on, go ahead and put that in the chat box, and I'll be paying attention to that as we kind of move along. But I want to make sure that this isn't just me talking, because I don't know that anyone wants to hear just me blabber for an hour and a half, but that you guys are actually getting out of this what you would really like to. So if there are specific things that you want to know, go ahead and add them in there. I've got my chat box up so I can see when things are being added. Let's see. So this is kind of what we'll roll over today. We're going to go over schizophrenia spectrum disorders, mood, anxiety, trauma, personality disorders, and substance use disorders. These are not the only disorders that exist, right? The DSM, which is the guiding body for mental health diagnosis, is 500 pages long and has hundreds of different diagnoses. So that would be pretty boring if I went through everything. So we're going to really focus on some very key areas. And I'm focusing on these areas because these are the folks that generally are going to be presenting for support, for community treatment, and are the folks that you're generally going to run into in the community. So that's why we've chosen to focus on these ones today. Excuse me. So schizophrenia and the additional disorders in the spectrum, they share a lot of the same symptoms. So I thought we'd run through these really quickly. So when we think of schizophrenia or schizoaffective disorder or any kind of psychotic disorder, most individuals are thinking about what are considered positive symptoms. What are those? Those are things that are should normally not be there, but are. So we're thinking about hallucinations, hearing things that aren't there, seeing things that aren't there, feeling things that aren't there, and delusions. So a different understanding of the reality than the one that is actually being presented to you. So this is, typically what people think about when they think about schizophrenia or psychosis in any form. A lot of people don't necessarily think about the negative symptoms. So these are things that should be there, but that are not. And so this is diminished emotional expression, right? Decreased ability to experience pleasure, and then like a decreased content of your thoughts and your speech. As well as some cognitive symptoms. So deficits in executive functioning, right? So that's the inability to pay attention, to plan, to organize, to follow through. And so I'd really like to point out that individuals experiencing schizophrenia who are even on medication, who are getting treatment, doing what they're supposed to do, medication is a really good treatment for positive symptoms, right? They decrease hallucinations, they decrease delusions. However, what medication often doesn't treat or doesn't do a really effective job of treating are those negative symptoms and cognitive symptoms. So even someone who's doing really well, they're taking meds, they're getting treatment, are still going to experience a greatly decreased ability to feel joy, right? To feel any emotion. To be able to organize their life in a way that is helpful and making sense to them. And so when we think about, the symptoms of schizophrenia, folks that have it well managed, do not have delusions, do not have hallucinations, However, they're still greatly impacted by their symptoms that aren't necessarily controlled by medication. And I'd also like to point out that individuals with schizophrenia, usually they start experiencing symptoms between the ages of 16 and 24, so late adolescence to early adulthood. And if you can imagine, for folks who are, in that age range, their brain hasn't actually finished developing yet. And there is a lot of research going on regarding the number of times that someone has a psychotic event and the impact that has on brain development. So each time an individual has a psychotic event, there is irreparable damage that is done to their brain. And so that's why really focusing on getting folks the support, assistance, help, medication that they need as early as possible is so important. Studies have shown that folks that are stabilized on an antipsychotic early on in their symptoms have a much better outcome later on down the line. They have less damage done to their brain. They have a better outcome as far as being able to navigate both those negative symptoms and those cognitive symptoms. So the things that are really having an impact on people's lives are much better managed when folks get on medication earlier. So about 1.2% of the total US population has a diagnosis of schizophrenia. I would, however, like to point out that African Americans are 5 times more likely than whites to be diagnosed with schizophrenia. They are not 5 times more likely to actually have schizophrenia. They're more likely to be diagnosed. And that's for a variety of reasons. There's clinician bias, right? So we have an underrepresentation of African Americans as psychiatrists. And so there are cultural differences that are not taken into account when we have white psychiatrists seeing African American clients. Additionally, there's a range of focus on symptomology, right? So many psychiatrists focus on the presence of those positive symptoms, as opposed to really doing what they can to navigate all of those other negative and cognitive symptoms that play a bigger role in the diagnosis of schizophrenia. And so, additionally, like many other health disparities that exist among the African American population, is folks don't necessarily have health insurance. They don't necessarily have places in their community that they can go for treatment. And so those folks are presenting a lot later for treatment in their symptoms. And so folks that might have a mood disorder, but it has progressed so far that they are starting to have much more serious symptoms, present to a doctor, and a doctor that might not be as skilled as they really need to be are not really digging into all the symptoms and are focusing on those positive symptoms, so misdiagnosing folks. Why that's important is because most antipsychotics are not going to do a great job for someone with a mood disorder. So what's unfortunate is that these individuals who are presenting finally for help and getting misdiagnosed are then given the wrong medication, and a medication that is probably not going to really effectively manage their symptoms. And then they're probably going to stop taking that medication because it's not managing their symptoms. So this kind of leads to, a cycle of folks in and out of treatment, getting misdiagnosed, re-diagnosed, continuously getting wrongly diagnosed. So it is just another example of the health disparities that exist between racial groups in St. Louis and in the U.S. Before I move on to the next area, are there any questions, comments, concerns, additions that folks have? I'll give you all a few minutes if you do have any before we move on. I'll say this is very weird for me because usually I'm a pretty dynamic, I do really well face-to-face, so staring at the computer screen waiting to see if there's a comment is weird for me. So thank you for bearing with me. All right, we'll go ahead and move on. Awesome. So mood disorders. This includes depression and bipolar, and there are many varieties of depression and many varieties of bipolar, but without kind of getting in the weeds about each, I wanted to give a pretty broad overview of what's included in these. So first of all, individuals with a mood disorder make up about 10% of the population, and major depressive disorder is actually the leading cause of disability among American adults, so ages, I think, 16 to 64. And so this has a large effect on people's ability to manage their day-to-day tasks. So depression, right? We've all heard of this. I'm sure lots of people know an individual suffering with depression. So we've got general loss of interest or pleasure, changes in your sleeping and your eating patterns, generalized fatigue, low self-worth, as well as thoughts of death and suicidality. And so, you know, again, presenting for help early on is really important, because the ability to manage some of these symptoms when you're just starting to feel them is you have a much better outcome before you're getting down to the space where you are feeling suicidal. So we actually got, I'm going to pause here for a minute. We got a question that can be easily answered here. So in these times, the importance of telehealth services for clients is becoming more pressing. Are you familiar at all with reputable training courses and opportunities? Man, they're like fast flowing these days, right? With everybody scrambling to figure out how to provide services. I actually just am in the middle of taking a free online telehealth course by PESI. That's PESI. They're one of the national training collaboratives for individuals needing continuing education in the helping professions. It goes very much into detail. So if you're looking to, start your own practice in telehealth, I would greatly suggest doing that training. However, the biggest thing for being able to address people's needs is going to be the same whether you're face-to-face or whether you're over the phone. And that's being able to listen, to provide validation, to create a safe space where people feel like they can share what's actually going on, and keeping an open line of communication, right? So as strange as it is these days, really shifting to telephonic and video therapies, I think that a lot of the main tenets of good practice remain the same. And so it's figuring out what your personal style is going to be, how that's going to look different via video or over the phone versus face-to-face. I know I can be kind of sarcastic, so I had to figure out how to check that a little bit when you don't have face-to-face contact with someone. And so it's definitely been a learning curve for folks, but I think that your ability to have your personality and your skill set transfer to a different mode, I think is one of the most important things. And so I focus not so much on, how to change my practice to make it viable via telehealth, but more how I can continue to portray the care and concern that I have for my folks, and the ability to continue to accept their personality and show my personality in a way that's not necessarily us in the same room. So that was a very roundabout way, and I hope it actually did answer some of your questions. If it didn't, keep things coming, and I'll continue to kind of give input as I can. So we'll shift back to depression. Again, when depression gets severe enough, there are tendencies for individuals to have thoughts of suicide, thoughts of death. And I think when we think about that, people are really scared, right? We as clinicians and community members, you know, one of the things, oddly enough, that's kind of been ingrained in us is, you know, I think, and this is part of, you know, our US culture, is that we don't want to talk about bad stuff, right? We don't want to give people the idea that they might not already have. So it's been ingrained in us to not really talk about suicide, not talk about this. And I think that's led to some pretty poor outcomes for individuals. I think the easier it is for you to talk with someone frankly about how they're feeling, the better their outcomes can be, right? And so that means being able to ask someone if they're feeling suicidal in a totally non-judgmental way, right? Because if someone knows that you are willing to talk with them about their actual feelings and not freak out and run away, they are much more likely to turn to you and really talk through their emotions, as opposed to keeping things bottled up and making, you know, a very final decision. One of the things that's really interesting to me is that I think it's like 95% of the individuals that attempt suicide started thinking about hurting themselves or killing themselves in the past half an hour. And so when we talk about addressing suicide, we are really talking about giving people time to really think through their decisions, right? And so a lot of this means keeping an open avenue of communication and making sure that you're checking on people that you love, whether that's in a professional setting or whether that's in a personal setting. Because again, all it takes is someone to interject themselves in that thought process to stop what could be, like I said, a very final decision. And so those are kind of my thoughts on suicide. I deal a lot with chronically suicidal individuals, and it can be really hard. But I also believe that being open to the conversation is the first step in really working with folks, either again in your professional or personal life, who are dealing with those suicidal thoughts. Additional mood disorder of bipolar, right? So this includes both symptoms of depression as well as symptoms of mania, and in some cases, psychotic symptoms as well. And so we talked about depression, right? The other side of bipolar is the mania, which is going to include these symptoms: elevated self-worth, poor judgment, risky behavior, racing thoughts, easily distractible, rapid speech. This includes also a high rate of suicidality and accidental death. And so if you can think about why that is, right? So if you're having mania, you're generally feeling like the best you, right? So you're feeling like the most creative, the most invincible, the most put together, best human that's ever existed, right? And when you're having that elevated self-worth, you're not really paying attention to the things that you're doing and how that is a risky behavior, right? And so we talk about, drug use, accidental overdose. We're talking about accidental death via driving. We're talking about lots of ways that people can unintentionally harm themselves because they are feeling euphoria beyond belief. Additionally, folks that are experiencing mania are pretty averse to taking medication, right? I wouldn't want to take medication if I were feeling like the best me. And so, both personally and professionally, I guess it's really important to, when you're talking with folks about the idea of getting help, getting treatment, taking medication, doing it while they're in a manic episode might not be the most fruitful time to be having that conversation. Talking with folks when they're feeling depressed, right, and when they don't want to feel that way anymore, can present with many more opportunities than trying to talk people out of feeling their best life. It's also hard to keep folks taking medication regularly because, you know, they want to feel good, right? Mania feels good. And so I think recognizing that that's real life, right? And people don't want to feel like shit. And, you know, mania is the opposite of feeling like shit. And so just helping people really recognize that those ups and downs in helping them kind of regulate the medication that they're taking is super helpful. So again, African Americans are greatly underdiagnosed, right? For a lot of the reasons that we talked about in the previous slide. So they often show up for treatment much later in their disease process. And so they are often showing up with symptoms of psychosis or greatly uncontrolled mania. And so clinicians are more apt to diagnose these individuals that actually do have a mood disorder with a psychotic disorder, unfortunately. Got another question, and this will be it for this slide. So as I answered this question, if anybody has anything else, go ahead and type it in before we move on to the next one. Just got a question, how do you not become judgmental of others while providing services? I often think that I am so lucky to have been supported throughout my life, and having a strong support network has gotten me through my own mental health challenges. And I think that had it not been for that support network, I could easily be in the space that some of the folks that I work with are. And so it is oftentimes easy for me to recognize that. And I think remembering that everybody's fighting their own battle, right? Whether it's the person sitting across from you in services, whether it's the person next to you in line at the grocery store, whether it's your roommate. I think everyone has their own battles, and not comparing battles to each other. Everything's relative, right? Your struggling should not be compared to my struggling. And so I think putting yourself in that mindset that how can we help you in your personal battle and not compare it to someone else's is a really awesome way to be able to approach people in a really non-judgmental way. It's a great question. Got another question. Would you be able to share your slides with us? I will go ahead and send this PowerPoint to Chris Stalter, who you all were communicating with for registration, so that he can send that out. Hopefully that's okay. If that's not okay, we'll figure something else out. Great questions, guys. Let's see here. We'll go ahead and move on to anxiety. All right, so anxiety disorders are kind of an umbrella term for a pretty large range of disorders. And however, all of those disorders have pretty similar symptomology. You know, when we talk about anxiety, most people think of generalized anxiety, right? Like just a general sense of worry about everything all the time. I'd also like to include that obsessive compulsive disorder as well as post-traumatic stress disorder are technically anxiety disorders. We'll talk a little bit more thoroughly about trauma and post-traumatic stress disorder in a little bit, so I'll save some of that. But when we talk about anxiety, you know, this is one of the most common behavioral health issues among Americans. 18% of individuals in America suffer from an anxiety disorder. And I think that I'd like to point out that anxiety disorders are actually less prevalent in minority groups. So it's definitely a non-Hispanic white disorder, right? And I think a lot of that has to do with the fact that non-Hispanic whites are much more likely to present for treatment somewhere, and additionally have, you know, I think a lower threshold for general stress. So when we talk about what it's like to be a minority in our country, there is an onslaught of different types of trauma and stress. And I think at some point, individuals in minority statuses have to sort of come up with a threshold for which they're able to manage it, where individuals who do not have that onslaught of stress and trauma throughout their life do not have that same threshold. And so I think it's a lot, it's much more prevalent for whites to present for treatment for anxiety, even though they are not necessarily the only ones experiencing the symptoms. So I'd like to keep that in mind, that when we talk about percentage of individuals, that's percentage of individuals who have shown up to get a diagnosis. And so that oftentimes really leaves out large portions of our community. So again, when we think about anxiety, I think a lot of folks think like stage fright, or I get anxious before a presentation, or anxious to meet a new person. And that is definitely like one end of the scale, or of the spectrum of anxiety disorders, but they can go all the way through to the other side of the spectrum, which, excuse me, is going to include, overwhelming feelings of panic and fear, intrusive memories, intrusive and obsessive thoughts that are often uncontrollable, nightmares, physical symptoms, avoidant behaviors. And so when we think about the other end of the spectrum, we're thinking about someone who has such gripping fear of leaving their home that they have not seen another person face to face in years, because their ability to go outside is totally overwhelmed. Their system is overwhelmed by feelings of panic and fear and circular thoughts of what could happen if they go outside, that builds up and builds up and builds up until that fear is so strong that they would rather stay inside than have any possibility of something negative happening to them outside. So I think that it's really important to remember that there's a pretty broad range of symptomologies for anxiety disorders. Also, anxiety disorders have about a 50% comorbidity rate with depression. And you can probably see why, right? Like if everything were so fearful that you couldn't really live a life that you found enjoyable, it could easily lead to those negative thoughts of self and negative thoughts of the world that oftentimes lead to depression. Excuse me. So we got a question regarding anxiety, and if other folks have questions, you can go ahead and send them in. We have, will anger be classified as a symptom of anxiety disorders? And so that's a kind of hard question to answer, because I think anger can, so I like to think of anger as the iceberg emotion, right? So if you can imagine that anger is the very tip of the iceberg, right, that's peeking out above the water. But we know that icebergs have a vast amount of ice unseen below the water. And so anger is what you can see, but it's not necessarily the whole picture. And so in order to kind of understand how, where anger is stemming from, it's really important to understand what's causing the anger, right? Is the anger like a pretty appropriate response to a situation? Maybe. Is anger stemming from your inability to see good in yourself or the world? That might stem from more depressive symptoms. In some cases, anger could absolutely be a symptom of an anxiety disorder. Anger is also can be a symptom of someone experiencing paranoia or delusions as part of a psychotic disorder. So I think it's really important to remember that anger itself is just that tiny little piece of the iceberg that you can see, and that it's really important that if you're wanting to learn more about that person, kind of what are those underlying emotions that are having an impact on that anger, and what is not necessarily being shown. Sadness, frustration, overwhelming, distrust, all of those things can be outwardly expressed as anger. So I think anger is, like I said, a broad emotion that probably takes a little bit more to get a little bit more familiar with what's causing it. I hope that was a good answer to your question. Awesome. You guys are great. Thank you for all the questions. I appreciate this. Any other questions regarding kind of anxiety before we move on? And if you do, we can always go back. No problems here. All right, trauma. I will do my best to keep this semi-short and sweet. This and personality disorders are my jam. And so I can often get soapboxy. So I will work on checking my soapbox for you all. You're all like, you're good thing your videos are off. I don't want to see like the eyes rolling as I keep talking. So trauma is super important to understand in mental health, as well as just being a community member. So individuals with behavioral health disorders or issues, 100% of the time have experienced some sort of trauma. And I'd like for us to work on expanding our understanding of trauma. And I think those in the Black community absolutely have an expanded view of that. I think anyone from a minority community has an expanded view of that, but I think those in the majority community can probably do a little bit better at recognizing the width and breadth of which trauma can fall under. So, right, lots of us automatically think childhood abuse and neglect as trauma. Yes, absolutely. I'd like us to broaden our view and look at the medical system and the mental health treatment system as traumatic. You know, when someone goes to a psychiatric hospital, they are stripped of their clothes, their belongings. They are told when to eat, what to eat, when to sleep. They have restricted movement. They are told to take medication that they don't necessarily have a choice in. When we think of our medical system, you know, individuals from minority communities don't present for treatment because there are doctors that don't believe them. There are doctors that minimize their symptomology because of the minority that they come from. In terms of the LGBT community, you know, for a trans person to find a doctor that is non-judgmental is real hard to come by. And so going to a doctor and having to explain your gender identity or the pronouns that you choose can be traumatic. You know, when we think about poverty, when you have to figure out how you're going to feed yourself and your kids every day, that's traumatic. If you don't have a home to go to, that's traumatic. When you see people around you kind of living a life that is joyful and yours is filled with constant struggle, that is traumatic. And again, like I said, being of a minority status is traumatic. Black and brown people in this country have a very different experience than white folks. And I think it's really important to not diminish the impact that different reality has on people. I think, yeah, it just can't be overstated enough. You know, trauma is really often misdiagnosed, right? So a lot of times, you know, I see it in working in a community mental health center. I often see trauma and PTSD misdiagnosed as a psychotic disorder. You know, if someone is coming in and doesn't have the vocabulary that you or I might have to explain what they're experiencing, but they just know that something is happening in their brain that may or may not be there. They might be behaving erratically because they're having flashbacks, because they're dissociating, because they're having such intense symptoms. It's easy for a clinician who isn't going to take the time to really understand their symptoms. It's easy for them to give a diagnosis of a psychotic disorder as opposed to taking the extra time and energy to dig a little bit deeper into those symptoms to see if they really might be coming from a place of trauma. And again, an antipsychotic is not going to heal someone's trauma. And so it just perpetuates the intensity of people's symptoms when they are misdiagnosed and given incorrect medication that can have a really detrimental effect on their on the way they experience their life. So we also have a pretty high comorbidity with substance use disorders and borderline personality disorder. We'll talk a little bit about personality disorders in a moment. But individuals with PTSD are 4 times more likely to have a substance use disorder than the general population. And when you stop and think about it, that makes sense, right? If you are experiencing intrusive thoughts of a trauma that you experienced over and over and over and over again, I could easily see where it would be much better to be intoxicated or high or having an altered reality than the one that is currently causing so much pain. And again, this is, harping back to a previous question regarding a non-judgmental stance for individuals. Very few people with a substance use disorder start because they like the way that it tastes or feels. Obviously some do, right? There's no universal, but most folks that have a substance use disorder are dealing with trauma. And I think reframing it in that way so that you can really understand where people are coming from makes it a lot easier to understand how they're choosing to manage it. Is it the healthiest way to manage it? No, but it's what's worked for them. And I think our job as clinicians and as friends is to help people explore better ways of managing the things that they find unmanageable than what they're currently doing, right? And so I don't like the idea of like a good coping skill or a bad coping skill. I often talk to my clients about a more adaptive or less adaptive coping skills because they're all getting their needs met, right? Some just have some pretty gnarly consequences and side effects. And so we want to really help individuals in our life figure out ways that are a little bit more healthy to deal with the symptoms that they're experiencing that won't leave such a lasting negative impact on them in the long run. So, when we talk about differences in minority status and trauma, it can be easily seen in this last bit. So this is differences in lifetime prevalence of PTSD by race. So general population, 7 to 12%. In the African American population, a lifetime prevalence of meeting the criteria for PTSD is between 30 and 50%. That is 1 in 2 individuals. And I think when we broaden our view of what is traumatic and the idea of chronic traumatic stress, it can easily explain why as many as 1 in 2 individuals in the Black community experience those symptoms. And again, it's, one of the things that I think is really important to ask people, which I love. I learned this at Places for People, is, we don't ask what's wrong with you, but rather what happened to you, because there's nothing wrong with anyone, right? Even if you have, schizophrenia or another behavioral health issue, there's nothing wrong with you. But I'm sure a lot of things have happened to you, and a lot of things have caused your life to be unhappy and hard. And I think it's really our job to, as clinicians, as community members, as friends, is to really be able to ask people in that non-judgmental way of what happened. And that often explains the symptoms that people are experiencing and the outward way that they're presenting themselves. That is a much better question to ask than what's wrong with you. Why do you act that way? Why won't you get help? Why won't you do this? Why won't you do that? I think that can feel pretty oppressive to individuals, but I think just changing the way that we're looking at it, and really we're striving to understand the background story that people present with, and understanding that can really help us understand why they're choosing to deal with it the way that they are. And then that's where we come in to help people maybe strive for handling it in a different, more adaptive way. I think I did pretty good for non-soapboxy. Sorry if anybody disagrees. Any questions regarding trauma? Because I think we're going to move on to personality disorders next. Either that or substance use. I can't remember. If folks do have questions regarding trauma, go ahead and type it in, and we'll view this as we need to. You guys are awesome. Thank you. I was right. Personality disorders. I was shocked when I learned that 15% of the US population experiences a personality disorder. And then as my shock faded, I had to remind myself that not everyone with a diagnosed personality disorder needs to present for the type of intensive treatment that might be provided at a community mental health center. And so when we talk about personality disorders, I've broken them down into their clusters, right? I've highlighted cluster B. This includes antisocial, borderline, histrionic, and narcissistic. This cluster is actually the most likely to present for treatment. And of those, individuals with borderline are some of the highest utilizers of mental health services. When we talk about individuals with borderline personality disorder, I'm sure lots of clinicians in the room, automatically go to some of the folks that might be the hardest to work with. They might present the biggest barriers to really working toward recovery. And I think that that's understandable, right? Folks that are experiencing borderline personality disorder are often frequently in crisis. They engage in really, really unstable relationships. They have frequent substance use. They have high propensity for self-harm behaviors. And I'd like to remind people that this is highly, highly linked with childhood and adolescent trauma. When we think about experiencing trauma as a child or an early adolescent, that kind of changes the way that you see your world, right? It changes the way that you are able to ask for what you need. And if the only way that you can get your needs met is through some horribly maladaptive behavior, as a 12-year-old who's neglected or who's been sexually abused, that might be the best that you can do. And so when we get folks with this diagnosis as adults, these behaviors that have absolutely gotten their needs met as children are not necessarily serving them as well as adults. And so, they often present with deficits in 3 areas that I've listed up here. So the inability to regulate their mood, a very low tolerance for distress, and pretty ineffective interpersonal interactions. And so when you think about those 3 things combined, it makes for really hard living, right? Figuring out how to navigate a life and relationships and friendships and a normal job, I think can seem exceptionally overwhelming for people who are unable to navigate those due to those areas that they struggle with. One of the best treatments for individuals with personality disorder is dialectical behavioral therapy. And it's a therapy that actually focuses on those 3 key areas, and it's highly skill focused, and it really focuses on practice of skills with clinicians, practice of skills with other individuals in a group, and then practice of skills in your real life. And so it is definitely people living with this diagnosis, things may oftentimes feel overwhelming, right? And I think being able to gain some skills that might serve them a little bit better than the ones that they're currently using, make life all that more manageable. Some of my favorite things as a clinician have come from DBT therapy. One of them is reminding myself that individuals are doing the best they can. If they could do better, they would do better. And so reminding myself that people aren't intentionally creating the chaos that surrounds them, but it's a byproduct of their choices and their behaviors. And also another favorite is clients might not have caused all of their own problems, but they are in charge and responsible for figuring out how to deal with them. And so that has gotten me very, very, very far with working with folks, is that recognizing that you're right, they might not have caused all their own problems. There are lots of things in life that happen that bring problems to you. But I think reminding people that even though they didn't cause it, they're still in charge of figuring out how to deal with it can help them be empowered and help them recognize that, yes, they did not cause all their because lots of folks kind of believe that they did. And so if folks are interested in learning more, I highly, highly recommend checking out dialectical behavioral therapy. They are skills that I use in my personal life. They are skills that I use with nearly every client that I've ever worked with. I just think that they're such great introductory skills on how to lead a more balanced and regulated life, whether you are living with a behavioral health disorder or not. And in some of our resources, I'll talk about a website that is a great introduction. Any questions regarding personality disorders? I'll give you guys a couple minutes to get stuff on there if you're so inclined. We've got substance use disorders, talking a little bit about COVID-19, and then a little bit about what you all can do left to go. So just to give people a little view of what we got left. Substance use disorders. About half of all individuals with a mental health diagnosis also have a co-occurring substance use disorder. So recognizing that they go hand in hand. And I think having talked about what we've talked about so far, that is kind of easily explained, right? If your life feels unmanageable, if your symptoms make daily interaction so overwhelming that you don't want to live in your reality, it makes perfect sense that you would choose to alter the reality that you have. And I really come to relationships with individuals with substance use disorders that way. People are using substances because it meets a need. And I think if we can understand what that need is, we have a much higher capability of helping them figure out what they can substitute to meet that need. And so I think that's the way that it makes sense to, come to individuals that you're working with, or individuals that you're friends with, or individuals in the community. Again, it also helps with that non-judgmental stance, right? Like, you understand why people are using substances. And I think if we can internalize the understanding, it automatically helps with that non-judgmental presentation. So substances, alcohol, illicit substances, or street drugs, over-the-counter medication, prescribed medications that are being misused, and the often forgotten nicotine and caffeine. Obviously, like, utilizing an opioid is probably more dangerous than utilizing caffeine. However, it's really important to remind ourselves that these all cause adverse effects in people's bodies. Especially, it's important to talk about nicotine. Individuals with substance use or with mental health disorders are much more apt to also use nicotine. And nicotine is one of the things that really has broad implications in physical health issues. It's been talked about that individuals with mental health disorders die on average 25 years sooner than the general population. And some of those reasons are physical health reasons, right? They're not dying from schizophrenia, but they are dying from heart disease and diabetes and complications for other physical health issues. And so I think paying attention to how individuals are utilizing substances is really important. You know, we have now in our new DSM, mild, moderate, and severe use, right? And so those are kind of looked at as what sort of impact they're having on 11 various life domains. And so, you know, obviously people can utilize substances and still lead a normal life, right? It's not necessarily impacting their ability to deal with their responsibilities. That does not necessarily mean that it is not having a negative impact on their life. And so I think really looking at how it's impacting all of your life and all those areas is important. You know, I also like to pay attention to the impact that minimal use can have on mental health symptoms. Minimal use for someone on an antipsychotic or a mood stabilizer can have a really large effect on the ability of their medication to work, on their ability to remember to take their medication. And so I think, you know, I am not taking an antipsychotic. And I think my ability to drink alcohol has a very different, that amount that I would drink has a very different effect on someone who's taking an antipsychotic. So I just think that it's important to remind ourselves that when we talk about use, we really do also need to focus on individuals that might have minimal use or really mild symptoms, because they can have kind of a disproportionate impact on some individuals. I'd also like to point out that despite news media portrayal, the prevalence of substance use disorders among African Americans is either on par or lower than the general population. I think that we as Americans have done a pretty shitty job of accurately representing minority populations. And I think this is one of the ways that it's been done, is really sensationalizing pockets of information so that it seems really generalizable. And I think this is one of those areas. And so I think, again, reminding ourselves that what we see is not always the reality. I would like to state, though, that African Americans are actually more likely to present for substance use treatment than whites. And so although they are not necessarily overrepresented in the general population, they may be overrepresented in those seeking treatment. So it's a nice thing, just a nice thing to remember. So we've got a question here. So someone has a friend diagnosed with depression and PTSD, going through therapy. He's much better, but is heavily dependent on weed because it was prescribed for his depression. So how do I help him? So I guess, you know, one of the first things to maybe do is talk with him about it, right? And not necessarily from a like, I want to help you stop smoking weed, but from the more like, what's your life like, right? What does it do for you? How you seem to be doing so much better. What's impacted that? How have you been able to get some of these things under control? And I think, you know, we're in this like really weird space right now where smoking cannabis is legal, right? In lots of places, and still can have an adverse effect on people. Can it also have a positive effect? Absolutely. Like we're in this like crazy middle ground of having to navigate this. And so I think maybe examining for yourself if his use of cannabis is impacting negatively areas of his life. And also like learning what it's like to be in his brain, right? Like how does he experience his world? Maybe his, you know, use of cannabis is actually making his ability to live in his world manageable. Not that that would be a nice forever thing, that use of cannabis, but that's what's working right now. And I always, with friends who have problematic substance use patterns, it's so touchy, right? But I think highlighting for people areas of their life that have kind of plummeted due to that substance use. In my circle, it's been a lot of alcohol use, and I think it's hard again because alcohol is legal, right? Drunk people are funny, right? And so it's like figuring out how to really talk to people about what you worry about them, how you worry about them, the things that are happening in their life that might seem out of control, and being listening, right? So like, again, listening is so important, because if I show up to a conversation with all the answers and I need you to do this, I'm like, your life is fucked up, like we need to help you, like interventions like that don't work, right? Because I mean, folks feel like you're not really listening to them. And so I think coming to a relationship by being able to listen and maybe understand a little bit about what their life looks and feels like can go a long way, because maybe they just need someone that they can tell how hard things are to. And so I'm, like I said, I'm a big proponent of listening and creating a non-judgmental environment. And we'll talk about that a little bit more in one of these next slides. So no awesome like magic answer, sorry, but listening is a great way to start learning about people and how they view their life and the things that they're doing in it. That's a really good question. You guys have been wonderful with the questions. I want to talk a little bit about COVID-19, because I would be remiss if I didn't include this, because obviously it's impacting how we do, think, and see everything right now. I found this quote on the interwebs, and it caught my attention, and I've used it in like 3 different things that I've worked with people. So this being COVID isn't just staying home and watching Netflix. It's abandonment wounds, it's relational conflict, it's touch starvation, it's existential dread, it's overwhelm of grief, it's lack of purpose, it's crippling anxiety, it's fear of death. And like when we reframe it that way, like I still feel it in my stomach, right? Like it brings a much deeper feeling than like, oh, I get to bake bread and watch Netflix all day. I think that people experiencing the things that they're experiencing, this is a nice understanding of why, right? We are being continuously bombarded with that traumatic stress, right, that I was talking about earlier. Stress of the unknown, stress of worrying about getting sick, stress of you lost your job, or maybe you're working overtime, stress that you can't see the people that you love. Right now, when we're talking about, reopening, stress of what life is going to look like when I try and go outside. Do I see friends? Do I not see friends? All of these things bombard our brain. And one of the first things to go when we have chronic stress bombardment is our executive functioning, right? And so our ability to follow through, our ability to think through multi-step processes, our ability to find internal motivation, our ability to regulate our emotions, all of those things. So I think looking at it in this way, I think maybe hopefully can have help people have a little bit of grace for themselves and for other people. And that there's no like right or wrong way to deal with this, because it impacts people in such different ways. And so I think not comparing your situation to someone else's. I was talking to someone who they quote felt like a whiny bitch because they have a job, they are fine, they're not sick, they like have a beautiful home that they can stay in, and he felt just so out of line complaining or worrying because he had all those things. And so I think like, that's awesome that he recognized that like other people don't have it the same way that he does. And it does not negate the feelings that he is feeling, right? It does not negate the way that he's dealing with his stress and feelings of being overwhelmed. And so I think recognizing that your emotions are valid, that other people's emotions are valid, recognizing that people are dealing with this in like a lot of ways that some might not necessarily seem cool to you. I think, again, having grace for yourself and grace for others and how to deal with this is really, really, really important. If people have questions or comments regarding COVID, I am happy to answer them or talk about them. Go ahead and use that chat box. We've got about 20 minutes left. We have a couple things to talk about, and then we'll have some time. I think we'll have some time at the end if people have other questions or comments that we can spend a little bit of time doing that. So before I go through these, I wanted to ensure that I answered one of the questions sent in about strategies for engaging clients who might be in denial or afraid of stigma. I love being able to accept people where they are, right? That's one of our biggest jobs is someone might present or not present, right, for help, but we know that they need it or are struggling without it. I think that a lot of people have great mistrust for the medical and mental health system, rightfully so. And so I think jumping in with, let's like give you these meds and let's make sure that you do the things that I say you do, I think can be really off-putting for individuals. So I think, again, starting with learning about them, right? Because if you learn about someone, you'll find an in for sure. Engagement, the engagement process for individuals into community services is sort of like building a new friendship, right? Like, you don't jump in to the stranger that you met on the street with like, come to my house for a sleepover. Like, that would be terrifying. Same way for people coming to get help, right? So it's like, it's learning about what their life looks like, learning about what's important to them. And I think people talking about what they love about themselves or what is important to them or what they want their life to look like is much more disarming than tell me about your life, like your lifelong trauma. Tell me about the symptoms that you're experiencing that make your life unmanageable. And so I think starting with figuring out where the person wants to be in the future, it can open up just so many conversations about what's keeping them from getting there. And that's how you get people kind of bought into the idea of help, right, or treatment. Because if folks aren't bought in, like, it's not gonna happen. Nothing's happening. And so I think building the relationship so that people can trust you and building a strengths-focused relationship, right? Like, how do we get you to where you want to be, as opposed to you have all this shit wrong with you, like, how are we going to fix it? So I think, again, just changes in how we're framing our conversations with people can have, it's such a small thing for us, but can have such a pretty, like, immense impact on people's interactions with us. Again, hope that was helpful to ever put in that question. And how you can help, right? Lots of things we've talked about already. Reducing stigma by normalizing discussion of emotion, right? We as Americans have been taught that emotions are private. You shouldn't talk about them, that you should feel them and suffer in silence. And I think that we are having to fight back against just like a huge cultural norm by discussing our emotions. And it's okay to feel sad. It's okay to feel angry. It's okay to feel frustrated. Because normalizing the conversation about emotions can then lead to like normalizing better ways of dealing with them. And so I think if people are open about discussing them, they are also more open to figuring out how to manage them in a way that's not detrimental. The idea of accepting people's views of their own reality, right? even though like what I might see from the outside might look terrible or might look great, who knows? I think it's really important to spend the time listening and seeing how people experience their world. Because if I come in to friends or clients with this idea of what I think they need to change or how I think they need to act, again, super off-putting. But I think if I present with wanting to understand what their world feels like, you know, that feels like I'm joining with them, like that we're going to do it together, not that I'm telling them how to change the way that they act or see things. We've talked a lot about creating a safe and non-judgmental space and how to do that, right? If you don't have a safe space for people, so both like physically, right, a safe space to be, but also psychologically, a safe space where people can share without fear of judgment, you have nothing. Like there will be nothing. There will be no friendship. There will be no clinical relationship. And so I think the foundation of like a human interaction, so much of the outcome can be harkened back to, does each individual feel physically and emotionally safe in this space that we've created? And so I think, again, the engagement process, whether it's a friendship or whether it's a clinical relationship, is just so important, because that's where you get to basically set the ground rules, right, about how you're going to interact with each other. And like, if, again, first impressions, right, if you screw up a first impression, it's really hard to come back from that. And so in friendships, it's important, just as in clinical relationships, if you screw up a first impression, it can take a lot of time to kind of come back from that and heal that. Not that it's not possible, but that it takes a lot of extra work. So it's important to put the energy and effort in the front end. We've talked about these last ones, right? Listening. I cannot overstate the importance of listening and like shutting our mouths for a minute and listening to what other people have to say. Because if we don't understand what other people feel, like what are we even doing here? And so shutting up and listening is great. Validating people's experiences, right? They might not be the experience that I'm having, but like it's valid. What they're experiencing is valid. And I think so often people are told that the way that they're experiencing things is wrong. The way that they're feeling is wrong. The way that they're responding is wrong. And so I think, again, our job is, as community, as friends, as clinicians, is to flip that script, right? In that it's not wrong, it's a way. There are lots of ways, and it is a way. And I think if we can validate that what they've chosen is in fact a way, that opens up the conversation and opens up the relationship for figuring out maybe a better way. Or an easier way. And so I think without first validating that what people are doing is the best that they can do with what they have, we don't have a whole lot. And lastly, referring for help, right? Might not be, you know, right for everybody, but I think that especially now with people being isolated and with people not necessarily having the support network that they usually have to deal with the barriers that they might be facing on a daily basis, I think now more than ever, it's important for people to have a place to reach out to. I've included some community resources for folks. And if anyone has things that they would like to add or questions or concerns about that previous kind of how to help slide, go ahead and shoot them my way. But so I know there might have been some Illinois folks on this training. I apologize, these are all St. Louis City, County, Missouri focused. I would like to add Chestnut Health Systems, which is the Illinois version of a community mental health center for individuals on that side of the river. But I wanted to point out that here in Missouri, we have something called a Certified Community Behavioral Health Organization. There are 3 in our area. Places for People, where we're from, is one, serving St. Louis City and County. Compass Health Network, serving St. Charles County, and Comtree, serving Jefferson County. The reason I pointed these out is that part of the Community Behavioral Health Organization mandate is that individuals must take clients regardless of their ability to pay, right? So all of these places have sliding fee scales. And so You know, I know that a big barrier is insurance, right? How are you going to pay for stuff? And so these 3 places are required to take you regardless of if you can pay for it or not. And so that is the thing that our, you know, our area has that I think cannot be too overstated as well. Additionally, all 3 of these places have the same types of programming, right? They all 3 have programming for adults with serious mental illness, programming for youth, programming for substance use disorders, and programming for like psychiatry and therapy. So they all have very similar programming as well. In addition, St. Louis metropolitan area has a wealth of support and resources. Our community mental health centers include BJC Behavioral Health, Hopewell, Adaptive Missouri, and Independence Center. And in the community resources handout that you'll all be sent after this, it actually has phone numbers, like the intake phone numbers for all of these places. So making things a little bit easier. Additionally, BJC has like way more places than I thought they did. So they actually have places that serve St. Francis, Washington, and Iron counties as well. So they all have the same number. So just so you know, there's a wealth of places for support. Let's see. I included behavioral health response. They are a 24/7 behavioral health hotline where if you're experiencing a behavioral health emergency, they will help you get connected to crisis counselors, hospitals, evaluation teams. They're wonderful. They will also help make referrals if you are facing you or someone you love is facing a serious barrier or a psychological emergency. They also make referrals to agencies in the area for support. And the last thing I have here is my absolute favorite website that has ever been made in the entire world. It's nowmattersnow.org. It was created for individuals experiencing suicidal ideation, but it can actually be used for anyone experiencing distress or mood dysregulation. It's super awesome. It has videos made by individuals who are actually experiencing symptoms. It helps walk through skills to bring distress levels down. And it also has a resource page which has like nationwide crisis text lines, IM lines, specialized crisis lines for veterans, the trans community, teens. I just think everything on it is amazing. It has stuff for clinicians, it has stuff for individuals experiencing distress, it has stuff for friends and family members. This is a website I give to everyone. Every single person I do therapy with gets it. I again cannot overstate how wonderful of a resource it is. This last page that I'm going to move to has contact information for places for people specifically for all of our different programming. That is not included in the resource page, but again, I'm going to try and get this slideshow sent out to everyone, so you should have it. But I'll put it up there in case, just to give people time if they are interested in getting down those numbers. I got a question. Will we receive a certificate of participation for our agency to approve attendance for this training? I have no idea. Julie, will they be receiving one?
Yeah, if you need or if you would like a certificate of attendance, we are going to be sending out an email afterwards with a brief survey and Megan's handout, and we'll turn the slide presentation into a PDF. So you will be getting all of that, and then please reply with the survey and let us know that you want a certificate, and we will make sure that you get a certificate sent out to you to verify that you attended this training and that it was from 10 to 11:30. So that if that's helpful with work, we'll make sure that we get that to you. So please let us know when you reply to the email that will be coming out with all this information and with the survey included. And so please, if you have other questions, type them in. And I just want to give a quick wrap up while we're waiting. If you have suggestions for additional trainings that you think would be helpful for you or for your community or for your workplace, please let us know that, and we would love to make sure that we're meeting the needs of what people want information about. If you think that your workplace or your organization would, or a group that you're a part of would like one of the content experts from Places for People, or that is connected to our Regional Center of Excellence, please reach out to us and let us know, and we can work with you on a plan to see if, on how we could help you with that. I know right now we probably wouldn't be going out to your office, but we might be able to set up a Zoom or some sort of consultation that way. So if you want some individualized for your organization training, please let us know. That's something that through our Center of Excellence we can help you work on. And also with the with our funding, we were able to provide some attendance prizes, which is a $25 Amazon gift card. So if you, when we send out our email, we will notify you if you are one of the winners of our Amazon gift cards. We have several to send out. So there's a good chance that you might be one of our winners of a gift card. So be looking for that. And I'm just checking again to make sure I didn't get any new questions come through. Megan, did you get any other questions?
I didn't. And before you wrap up, I wanted to thank everyone. I know that this is like not an ideal setup for like a didactic training, but I super appreciate you guys shooting questions my way. It made my life much more enjoyable. And I've also included my email. I am more than happy if people have concerns, questions, want more information, want to talk about referrals to different things. I'm more than happy to be available. I want our community to really work on lifting each other up and figuring out ways to help each other. And so I put that out there that I'm always available. Y'all have been wonderful. Thank you so much.
Yeah. Okay, and thank you, Megan, for doing this and for being the person that kicked off our online training this way. So thank you so much for doing that and for all the information you provided. Thank you again to St. Louis ReCAST for their funding for us, but also just for the community and, you know, reaching out and trying to make sure that we're getting good support and education to the St. Louis City and St. Louis County, particularly in the Promise Zone. So thank you for all that St. Louis ReCAST is doing. And thank you everybody who joined us today. There is another training next Friday that Kevin Wells is doing around positive parenting. So hopefully you saw that. It's Mama said there'd be days like this, parenting in today's world. So if you're interested in that, please look on our website or and please join us next Friday and keep an eye on other things that will be coming out because we have more stuff coming. So thank you so much, everybody, for being with us.